Patent ductus arteriosus, PDA, is a condition in which the ductus arteriosus, a fetal blood vessel that normally closes shortly after birth, remains open. This leads to abnormal blood flow between the aorta and the pulmonary artery. The treatment for PDA depends on the size of the ductus, the severity of the condition, and the age of the patient. Below are the primary treatment options. Stammer 1, monitoring, watchful waiting. Indication for small, asymptomatic PDAs. Details. Small PDAs that do not cause significant symptoms may close spontaneously, especially in premature infants. Regular follow-ups with echocardiography and physical exams are required to monitor for closure or complications. Hattershar 2. Medical management. Indication. Primarily used in preterm infants with a hemodynamically significant PDA. Medications. Non-steroidal anti-inflammatory drugs, NSAIDs, indomethacin or ibuprofen are commonly used. These drugs inhibit prostaglandin synthesis, promoting the closure of the ductus arteriosus. Most effective within the first 10 to 14 days after birth. Acetaminophen, an alternative for infants who cannot tolerate NSAIDs, acts by inhibiting prostaglandin synthesis through a different mechanism. Considerations: close monitoring for side effects like renal dysfunction, gastrointestinal bleeding, or platelet dysfunction. Less effective in term infants or older patients. 3. Interventional catheterization indication for symptomatic PDA in older infants, children, and some adults, also for large PDAs causing significant left to right shunting. Procedure: a catheter is inserted through a vein or artery to the site of the PDA. Devices such as coil embolization or occlusion devices, e.g. Amplatzer device, are deployed to close the PDA. Advantages: minimally invasive, short recovery time. Risks: bleeding, infection, or embolization of the occlusion device. 4. Surgical ligation. Indication: for patients where medical therapy or catheter-based interventions fail or are contraindicated, and in very premature infants with significant PDA. Procedure: a thoracotomy or minimally invasive approach is used to directly ligate or clip the PDA. Advantages: provides definitive closure. Risks: complications such as bleeding, infection, vocal cord paralysis due to recurrent laryngeal nerve injury, or chylothorax. SHAR 5. Hybrid approaches. In some complex cases, combining surgical and catheter-based techniques may be beneficial, particularly in patients with other congenital heart defects. 6. Management of complications. If PDA has caused complications like pulmonary hypertension or heart failure, additional treatments include diuretics to reduce fluid overload, afterload reduction medications such as ACE inhibitors, oxygen therapy for severe pulmonary hypertension. Considerations for treatment choice. 1. Age. Medical therapy is more effective in neonates. Interventional catheterization is preferred for older infants and children. Surgery is often reserved for neonates with contraindications to medical therapy or when catheterization is not feasible. 2. Size and severity. Small, asymptomatic PDAs may not require intervention. Larger, symptomatic PDAs causing heart failure or pulmonary hypertension require prompt treatment. 3. Other factors: prematurity, associated congenital anomalies, response to prior treatments. Prognosis: with timely treatment, most patients with PDA achieve normal growth and development without long-term complications. Delayed treatment of large PDAs may lead to irreversible damage, such as pulmonary vascular disease or Eisenmenger syndrome.